Hello, my name is Naomi Chapman, and I will be presenting to you today on beta thalassemia. Beta thalassemia is an autosomal recessive disorder. It is caused by alterations of the beta chains in the adult hemoglobin, which then cause ineffective erythropoiesis. It is a microcytic hypochromic hemolytic anemia, and the morbidity and mortality rate associated with it are pretty significant. Approximately 1 in 100,000 individuals in the US, in the world, have beta thalassemia, although it is more rare in the US, but due to our growing diversity, it is important to be aware of. So here are the hemoglobin chains. We're going to kind of take a step back for a minute. We have three prevalent hemoglobin chains. Hemoglobin A, the primary adult hemoglobin A2, which is also an adult hemoglobin, and the fetal hemoglobin F. Each of these hemoglobins have four globin chains and each with a corresponding heme group. So for the hemoglobin A, which is the type that is primarily affected in beta thalassemia, the two beta chains are either like one is missing or there are no beta chains at all. So the pathophysiology of this, the decrease in the beta globulin chains then cause increased alpha globulin, which are just free because there are no beta globulin chains or they're significantly decreased. Because of the excess of these alpha globulins, they can cause damage to the cell membrane, which then mark them for hemolysis. So then they are broken down. There is an increase in just the heme molecules independently, and there is also an increase in the bilirubin and iron that you will find. Because of all of this, there is hypoxia that is occurring. So the bone marrow and spleen are then signaled to increase red blood cell production, thus starting the whole chain of events all over again. The types of beta thalassemia. So there's thalassemia major, which is also called Cooley's anemia for the man Thomas Cooley, who was the first one to find thalassemia major. So this subtype is homozygous, meaning you have two of those recessive genes present, and the beta chains are absent or only there in a small amount. Now, in thalassemia minor, this is a heterozygous thalassemia, meaning you only have one of those recessive genes. So, therefore, the effects aren't as significant because there is still beta chain production. Risk factors. There are no known environmental factors. This is a genetic disorder, so the ties are to people from the Southeastern Asian descent, Indian, North African, and Middle East descent, as well as having a family member who is positive for beta thalassemia because that is a strong indication. So how beta thalassemia shows up is going to depend on whether you have the major or the minor. For the, thalassemia major, the symptoms and presentation does tend to be a little bit more severe and significant. So if you have a newborn, they are typically going to be diagnosed before they are 2 years old. This is because it takes a while for the clinical manifestations to show when they are initially born, and for those initial months afterwards, they are still producing that fetal hemoglobin. So that is the primary hemoglobin being made. Thus, there is no need for the beta chains. And as the newborn gets older and grows, they shift from that fetal hemoglobin to the adult hemoglobin. And that's when you start to see these different signs of beta thalassemia. So, what are you going to see? You're going to see abdominal distension and hepatosplenomegaly. This is resulting from the spleen being overworked. It's breaking down those. um, you know, ineffective um, hemoglobin molecules, and it's also trying to produce more. The body always likes to be in that state of homeostasis. So you're also going to see failure to gain weight, low height and weight, and spinal changes. Um, and lastly, you'll see these group of symptoms, which are more primarily related to the increased iron that you'll see in the body. So the jaundice, the abnormal heart rhythm, the dilated cardiomyopathy, the pericarditis, hypothyroidism, and diabetes mellitus. In addition to those more classic anemia symptoms that you'll see, the shortness of breath, fatigue, dizziness, headache, leg cramps, pale skin, difficulty concentrating, and fast heartbeat. Now, our red flags are going to be those pathological factors. Excuse me, because the bone marrow is essentially expanding, trying to increase the production of red blood cells and meet those needs. It tends to make them weaker, thus making them prone to pathological fractures. One of the hallmarks, I would say, of beta thalassemia is the chipmunk phase. And again, it's the same premise of what's going on with the bone marrow, only in the skull. So the overgrowth causes them to have the chipmunk face, the prominent forehead, full cheekbones, depressed bridge of the nose, overgrowth of the upper jaw, uh, resulting in that classic chipmunk face appearance. So our diagnostic workup. Essentially, we're screening for the HBB gene and the mutations. This can be done through prenatal testing and genetic counseling, or it can be done while a woman is pregnant and the baby is still in utero. It also can be done during newborn screening. And it is important that if a sibling is found to have beta thalassemia because of the strong genetic ties, that you send the siblings for molecular genetic testing because they too are at risk of having beta thalassemia. Now, the molecular genetic testing itself is not used as a diagnostic indicator, partially because they're difficult to get. Not every lab does them, they're highly specialized. So, again, it is not used as a diagnostic um, tool alone. So, what we will use is the hemoglobin analysis, the CBC, and the peripheral blood smear. Now, what will we see? In that CBC, we're going to see microcytic hypochromic anemia. On that peripheral blood smear, we're going to see nucleated and microcytic red blood cells, as well as target cells. On our hemoglobin analysis, um, because thalassemia major is homozygous, we're going to see that complete absent hemoglobin A, kind of going back to that diagram that I showed you all earlier. Because there is no hemoglobin A, the body is trying to make up for that by increasing the production of the hemoglobin A2 and the hemoglobin F. Now, in the thalassemia minor, just because it is heterozygous, you may or may not see the hemoglobin A affected at all. It could be normal, it could be decreased. However, you are going to see elevation in the hemoglobin A2 and the hemoglobin F. In addition to total and unconjugated bilirubin being elevated. In our imaging, ultrasound is going to show that liver and spleen enlargement, but this will depend on the severity. Again, going back to the spleen and the liver working so hard during this disease process. The x rays, your long bones and your skull bones are going to present with that widening of the diplodic space relating to that bone marrow enlargement as well. But the skull specifically, you're going to see a hair on end appearance. It's called this because the skull bone literally looks like there are little hairs standing up on it, and it's illuminated a little more brightly. So that is a pretty specific indicator as well. Treatment. This is going to depend on thalassemia major versus thalassemia minor. So if you have thalassemia minor, you might not require red blood cell transfusions. However, if you have thalassemia major, you are definitely going to require these. However, you might need them on a regular basis, or you might be able to get away with occasional red blood cell transfusions. Um, Now, iron chelation therapy is something that both parties are going to need. And here listed are just some current medications being used for chelation therapy that are PO, they're pills by mouth. Another treatment option would be the stem cells, helping you to make healthy red blood cells. And a key takeaway from this is that we are not going to manage this alone as primary healthcare providers. We are going to be referring to a hematologist and supporting them in this effort. So, how are we going to support them? We're going to educate our patient on avoiding infections, encouraging them to get vaccines. Again, the spleen is working so hard during this process that it is essentially immunocompromised. So we want to do what we can to help our patient protect themselves. In addition, we want to limit iron in the diet. There's already an excess of iron floating around in the body that we don't need to add to it. Low or moderate intensity exercises has also shown to be helpful, as well as social support. This is a lifelong disease and process. They're going to need a lot of social support. These are some clinical practice guidelines. I couldn't find many that were updated. As you see, these are a little on the older side, so hopefully I'll be able to come across something a little more updated soon. These are some sources for patient education. We have the CDC, the Mayo Clinic, Medline Plus. I was sure to include the Kids Health resource just because a lot of these people will be diagnosed before adulthood, especially when it comes to thalassemia major. So just some specific resources from them. In addition to the Cooley's Anemia Foundation, again named after that Thomas Cooley. And it has a wealth of information. They do 5K walks, they raise money for research. They are backed by the CDC, so they are funded by them. So it is just a great resource for providers and patients alike. And these are my references. Thank you.